All right, everybody, we're going to begin week 2 of online instruction. And so today I have for you guys the lecture on respiratory anatomy and physiology. And so let's go ahead and get started. So the respiratory anatomy, some of the major structures include the right lung. And the right lung has an upper lobe, has the horizontal fissure, has a middle lobe, an oblique fissure. Oblique stands for an angled fissure. Oblique tends to mean at an angle. So you have this angled fissure. And then finally, we have the right lower lobe. As for the left lung has an upper lobe and a lower lobe only separated by an oblique fissure. In addition, the left lung has a unique feature called the cardiac notch, and hopefully, as you can hopefully guess, the heart is where the heart would fill the space right here where the cardiac notch is. And in terms of structure for lungs in general, the apex refers to the top of the lungs. The base of the lungs is the bottom part of the lungs. That would be considered the base of the lungs. And the hilum, essentially, if you cut off one of the lungs and turned it to the side so you were looking where this primary bronchus was actually entering into the lung tissue, that's the hilum. In addition, we have pleura that surrounds our lungs. So we have the parietal pleura and the visceral pleura. And the visceral pleura is kind of like saran wrap. It's directly touching the lungs. And then there's a little space in between. And then you'll have the parietal pleura, which is kind of like a Ziploc baggie. So if you think about it like this, just like draw a quick little example. If you think about a lung, we're going to have the visceral pleura directly touching the lung. And then we will have an empty, well, not totally empty, a space filled with fluid. And then we will have the parietal pleura, okay? So it would go lung, the visceral pleura, the pleural space or the pleural cavity, which is in the blue, and then the outermost layer being the parietal pleura. Okay. All right, and now we're going to talk a little bit about the upper respiratory tract. And so let's talk about the nasal cavity first. And so this section, I'm trying to get my mouse to work here. This section here is all considered nasal cavity, and it functions to moisten and to warm the air. Some of the structures within the nasal cavity include the nares, which are just the openings that we see from the face, the two holes on your nose that allows air from the outside to come in. And then we have the nasal concha. And so we have a superior, a middle, and an inferior nasal concha. And the nasal concha have little hair fibers on them, which helps to trap dust particles and any foreign particles and prevent them from going down into the throat and eventually down into the lungs. And so these concha, in addition to helping with moistening and warming the air, they also have somewhat of an immune function. In addition to these structures, we also have what are called paranasal sinuses. And so if you've ever had a sinus infection, then you can relate to this. We have 4 different sinuses located within our skull. And these sinuses are just air-filled holes in the skull bones. And their purpose in life, well, really they have 2. The one that I mentioned in the PowerPoint here is they help with the voice resonance. And the other function of the paranasal sinuses are to help lighten the load, lighten the weight of the skull. And so you can see here is the frontal sinus. It's just an open space in the frontal bone. We have the sphenoid sinus over here, which would just be basically an air-filled hole inside of the sphenoid bone. So that's what I'm referring to when I'm saying paranasal sinuses. So in addition to having the frontal and the sphenoid, which I've already mentioned, you can see in this picture, we also have maxillary sinuses. And the maxillary sinuses are the ones that are kind of right along your cheekbones. And then ethmoid sinuses are the ones that are just on the lateral bridges of your nose right by your eyes. Okay, so just on the inside corner of your eyes are the ethmoid sinuses. Lastly is the pharynx, and the pharynx is also called the throat. And there's 3 subsections of the pharynx. The first section is the nasopharynx. And the nasopharynx is unique because this is the only one that's an air-only passageway. And what I mean by that is if you look at the oropharynx and the laryngopharynx, these 2 are both connected to the mouth. So these 2 are both air and food pathways, whereas the nasopharynx is air only. So as I just mentioned, the oropharynx is located at the back of the throat. So whenever you swallow food, the first place it goes is the oropharynx. And then in terms of air, whenever you breathe in air through your nose, it's going to go nasopharynx, oropharynx, and then laryngopharynx. The laryngopharynx is the location where basically we're sorting out the substance that's coming through here. So if it is a food coming through, the laryngopharynx is going to send it down the esophagus. If it's air coming through, the laryngopharynx diverts it over here to the larynx. Okay, and the larynx is also the location where our vocal cords are located. So as you can see in the structure, we have this little epiglottis. And I just point this out because whenever we swallow food, what actually happens is this epiglottis folds over. And so I'll put like a little drawing on there for you. So the epiglottis, whenever we're swallowing food, it's actually going to fold over and block off the larynx and then, the trachea. So that food doesn't go down the windpipe. And so if you've ever said, you swallowed something, you start coughing because you are claiming that it went down the wrong pipe. That's a very literal sort of expression. Food can travel, quote unquote, down the wrong pipe. It can go down the trachea if the epiglottis doesn't close when it's supposed to. Okay. So now we'll move on to the next slide. All right. So as we are talking about the laryngopharynx, that brings us down to the larynx and the trachea. So the larynx is the location that houses the voice box and our vocal cords. So I just showed you on the last slide the epiglottis, and the structure folds over to block the food from going down the windpipe. The trachea is considered our windpipe. And some of the structures within the larynx itself then, so basically from here upwards, are things like the hyoid bone, which hopefully we remember that the hyoid is the only bone in the body that's not directly connected to any other bone. We have the epiglottis, which I just mentioned. We have some thyroid cartilage, and the thyroid cartilage, as you can imagine, helps to anchor and protect the thyroid gland. We have cricoid cartilage, which is just beneath the thyroid cartilage. And then we have this cricothyroid ligament, which connects the thyroid cartilage to the cricoid cartilage. And if you've ever heard of someone doing a criciotomy, then it's usually what occurs when someone needs to be intubated, but they can't get the intubation down the throat, so they end up doing a cric. That essentially they're cutting through this cricoid cartilage, and then they can put the tube in to the windpipe directly and start pumping air for the person. So the last two structures of the larynx that I will tell you about are our vocal folds. And so the picture that you see over here on the right, this is the best way to see the vocal folds. And so this picture on the right, essentially all that it is we made a cut like this, and then we opened it up. All right, so we're looking at the side angle here of right down the middle of this left picture, okay? And so the vocal folds, the vocal cords, we have true vocal folds, which you can see there. And we have false vocal folds, which you can see there, all right? And so the true vocal folds are the ones that are contracting and relaxing to help us produce sound. So here is now looking, these two pictures up here on the top left. Essentially what you're looking at with these is you have taken a cut. Sorry about that. You have taken a cut now this way, okay? And you're looking from the top down into the throat for this picture over here, okay? And so for this picture over here, the true vocal folds would be located, these little white bands here. And whenever we are breathing, so whenever we breathe in, these vocal folds are relaxed and they allow air to move down into the trachea. But whenever we talk, we tighten our vocal folds. They become contracted. So you can see these two things, they come together whenever we're talking, which is also why you can't inhale and talk at the exact same time. I'll give you a second to try. I promise you can't. So these are just the major structures of the larynx and the trachea. And one more thing I'll mention before I move on to the next slide. The false vocal folds, they essentially don't have a role in speaking or in phonation, except if you're screaming. That's the only time the false vocal folds will also aid in phonation. Okay. Let me clear all my drawings for you guys. Okay, so we kind of started up at the top with the nasal cavity, and now we're just working our way down through the respiratory tract. And the next structures that we'll talk about are the bronchi, bronchioles, and alveoli. So the bronchi, as we send air down the trachea is going to split into a left primary bronchus and a right primary bronchus. And then what's going to happen is each of those primary bronchi are going to split again. And that is where we form our secondary bronchi. So here's a left secondary, here's a left secondary. You can see the right primary splitting into a right secondary. Here's another right secondary. Okay. And from here, then these secondary bronchi also give off even smaller branches. And those smaller branches are the tertiary bronchi. Then what happens next is that these tertiary bronchi, they just keep dividing and dividing and dividing until you get even smaller and smaller little branches. And eventually, what's going to happen is they're going to divide and become so small. So where they're going to divide and become so small that it looks kind of like this. So once we reach this point, this would be the bronchiole. Okay, so the tertiary bronchi has divided, and that bronchi divided and divided and divided, and eventually we reach a point that's that looks like this. So we have a couple of different types of what we call bronchioles. We have the terminal bronchioles, and then the respiratory bronchioles. And so it's kind of hard to see in this picture, but I'm going to try and point it out a little better for you, hopefully. So we can see this would be a terminal. Here would be a terminal bronchiole. Here's a terminal bronchiole, and here's a terminal bronchiole. Okay, so we have 3 terminal bronchioles in this particular arrangement. And then you can sort of see, we're going to focus on this middle one, you can sort of see it splitting 2 ways. All right, and so each of those splits then is now going to be called a respiratory bronchiole. The respiratory bronchiole is going to give way to what we call the alveolar duct. Okay, and I'll just try and highlight that on there for you too. Okay, so eventually that respiratory bronchiole is going to give way to that alveolar duct, which leads us into the alveoli themselves, into the sac of the alveoli. Okay. Get rid of some of those drawings here. Now we can talk about the alveoli and the alveolar sac. So the alveoli, you can see them pointed out here. The alveoli are the site of gas exchange within capillaries. And so I'm going to see if I can anyway. You know what? I can't do it. Darn. Okay. Sometimes I can zoom in on these pictures. Oops. No, it's not letting me. Okay. Well, the alveoli are the location where gas exchange is occurring. And so you can see on this image all of the go back to my spotlight here. You can see on this image go the vessels here. So the blue vessel would be a pulmonary arterial, because remember, if you think back to whenever we talked about the heart, and let's just remember that for a second, shall we? Let's think about the heart. Okay, so while we do that, let me just pause this for 1 second. Okay, so we were talking about the pulmonary arterioles and pulmonary venules, and I just wanted to bring us back to the heart for a second because I think this is a very important point. So if you remember, blood is going to enter into the right atrium, and then it's going to go to the right ventricle. Okay, and so it's entering from the superior and the inferior vena cava. And remember, this blood does not have oxygen. Okay, so I'm representing it as being blue. From the right ventricle, if you remember, we have on our heart the pulmonary arteries. Okay, and so the blood is going to travel from the right ventricle. Again, this is blood that doesn't have oxygen, so it's still blue. It's going to travel out to the lungs in order to get some oxygen. Okay, and so the lungs will put O2 in, take CO2 out, and the lungs now will send oxygen-rich blood into the left atrium, and then it will go to the left ventricle, and then it will go out the aorta. Okay. I am bringing all of this up because in the lungs, the pulmonary arteries oxygen poor, so they look blue. The pulmonary veins, the ones that are bringing the blood back to the heart, are oxygen rich. So they appear red. Okay, so I just wanted to bring that up and point that out. So hopefully that makes more sense whenever I go back to the PowerPoint really quickly here. Okay, so back to the vessels here. So again, notice that the pulmonary arteries are these blue ones, and then we come upon pulmonary capillary beds until once we drop off the CO2 and pick up oxygen within the alveoli, then we'll send that oxygen-rich blood to pulmonary venules, which will eventually lead to pulmonary veins, which will dump the blood back into the heart. Okay. All right, and so this picture, it's just a very similar picture showing nearly identical things, just from a different view, and you'll understand why I gave you this picture later. All right, so let's talk the respiratory tracts and the pathway. So I mentioned this before, but I'll just reiterate. The respiratory tract is actually broken into two separate tracts. And so sometimes you'll hear someone has or maybe you've had an upper respiratory tract infection. That's referring to an infection in either the nasal cavity, the pharynx, or the larynx. Alternatively, there are also lower respiratory tract infections, such as pneumonia. These occur in either the trachea, the primary bronchi, or the lungs themselves. Okay, and so within the lower respiratory tract, we have two different zones. We have a conducting zone, which includes the trachea, the bronchi, the bronchioles, and the terminal bronchioles. And then we have a respiratory zone. And the respiratory zone are those fine little teeny tiny branches that derive directly from the terminal bronchioles called the respiratory bronchioles, which give way to those alveolar sacs. And so basically anything in the conducting zone does exactly what you think it does. It conducts air from the external environment to the alveoli, and then conducts air back out to the external environment. The respiratory zone is the location where gas exchange is actually occurring. And so this is again occurring, including the respiratory bronchioles and the alveolar sacs. In terms of the way that air comes in, we've kind of already mentioned this, but I'll mention it once more. We start with the nose, and then you have the nasopharynx, oropharynx, laryngopharynx. So nose, naso, oro, laryngopharynx. And then we go into the larynx, and then the trachea, and then, oops, sorry about that. And then the primary bronchi, which split into secondary, so we have primary, which would split into secondary bronchi, which would split into tertiary bronchi, which split into bronchioles, which split into terminal bronchioles, and each of the sorry about that again, the terminal bronchioles are going to split and give way to the respiratory bronchioles. And finally, the alveoli. So that's the pathway that air takes from the moment that it enters your respiratory system all the way down to the alveoli. And then it would go from here all the way back up for the breathing out phase. Okay, so that takes care of the anatomy, but since this module includes both the anatomy and the physiology, I have to give you guys a quick lecture on some physiologic things that are going on within the respiratory system. So We think of the respiratory system as performing what's called pulmonary ventilation. And pulmonary ventilation is just moving air in and out of the lungs that occurs in two phases. So we have respiration, and respiration and inspiration are the same things. Okay, so respiration, also known as inspiration. Okay, so respiration, also called inspiration. Okay. Expiration then is the breathing out phase. And the ability of our bodies to breathe in air and exhale air is driven by the volume and the pressure of the lungs. Okay, so it's driven by lung volume and pressure. During inspiration, we can see that the thoracic cavity or the rib cage is going to get bigger thanks to the external intercostal muscles contracting and the diaphragm contracting. And so we know, so you're aware, if you look at when the diaphragm is relaxed over here, you can see that it's sort of this, I guess, sort of semicircular balloon type shape. And when it contracts, it actually moves downward. And this is what makes more space inside of the rib cage for air to fill our lungs. Now, whenever we breathe out, however, this is going to be caused by the relaxation of the external intercostals in the diaphragm. Alternatively, if we do forced expiration, so if you're breathing out and all of a sudden I was like, okay, breathe out as hard as you possibly can and let go of any remaining air in your lungs, push it all out. That's forced expiration. And forced expiration, we actually have to have muscle contraction, and the muscles that contract for forced expiration are the internal intercostals. Okay, so let's talk a little bit more about these pressure-volume relationships. All right, so pressure-volume relationships, the best way to understand them and describe them is thanks to Boyle's law, which states that pressure and volume are inversely proportional. And what's that? And what does that mean? Essentially, what that means is that if the pressure goes up, then the volume has decreased. Okay, it has to decrease. So they are inversely proportional, meaning if one goes up, the other goes down. This P1V1, P2V2 is just the mathematical relationship of this. And so what I will do for you is kind of go through each of these individually. And so the volume is the thing that's being changed whenever we do inspiration, okay? And so if we start breathing in, the volume increases, okay? So if we start with a pressure, let's do a pressure of, at resting, it's 760. Okay, so pressure 1 is 760. And we'll say the volume 1 is 1 for simplicity's sakes. If we were to increase the volume, so now volume 2 is going to be 2. That means that we have to do something to the pressure now to make this equal this. Okay, so let's go back to this. So 760 times 1, so that's pressure 1, 760 times volume 1 of 1 is equal to 760. Piece of cake, right? Now, this second half of the situation here, if we have a volume of 2, we have to multiply by some pressure to still get 760. So, with that being said, since our volume in this case doubled, our pressure needs to be a half of what it used to be. And so in this case, it needs to be 380 because 380 times 2 is 760. And we want those to be equal to each other. So in this scenario, when we increase the volume, which we do whenever we breathe in, you can see that we decreased the pressure, right? So we breathed in, our lungs got bigger, the volume increased, and therefore the pressure decreased. So the starting pressure was 760, the same as air, and now it's 758, okay, in this example. All right, so hopefully that makes sense. I know this can be a little bit physicsy, but just know that if one thing increases, the other thing decreases. So the opposite here is true. Actually, let me just go back for 1 second. So I said that the pressure decreases. And this is relevant to the respiratory system because if there is lower pressure inside of the lungs than in the air, what's going to happen is that the air says, oh, it's lower pressure in there. I would like to be in there because it's a lower pressure circumstance, right? And so now the air is going to travel from the outside environment into the lungs where it's lower pressure, and that's how we breathe in. Okay, so the increase in volume lowers the pressure in the lungs and air moves into the lungs. The opposite is true for exhalation. So as the lung volume gets smaller, decreases, then the pressure gets higher, right? So if you ever think about pressurizing anything, it's basically compacting it, and like a pressure cooker. You hopefully have some experience with that. But essentially then what's happening here is that the volume is getting smaller, so the pressure is rising. Because the pressure is rising and now it's higher here than it is outside, the air decides to escape and go into the external environment, which is why we breathe out. Exhale. Okay. All right, so I believe the last thing here that we have to talk about is spirometry. And spirometry is just this very cool machine that basically measures the amount and the rate of air that a person breathes. And it's only done if there's a suspected respiratory illness, or to determine if a respiratory illness is being treated properly. So essentially what happens is you have this cool machine and you breathe into it and it records these waves, right? So if you're like breathing in, it goes up, and then if you breathe out, it goes down. If you take an even bigger breath in, it goes up higher, And then if you take a huge breath out, it goes even lower. Okay, and so that's kind of how this machine is recording. And we have several different values that we can measure based on the spirometer. Okay, first one is the tidal volume. And the tidal volume is these short little waves here. And the tidal volume represents normal breathing. This is how much air you breathe in and how much you breathe out every time that you're breathing. Right now, you're probably just sitting at your house listening to me talk and just breathing really shallow, normal breaths. And that's the tidal volume. The expiratory reserve volume refers to, if I were to say, okay, regular breathe, regular breathe, regular breathe, and okay, at the end of your regular exhalation, push out all of the extra air that you can. All of the extra air is the expiratory reserve volume. Alternatively, if you were just sitting there regular breathing and I was like, okay, now take a huge deep breath in, the biggest breath that you can get in. To find the inspiratory reserve volume, it's whatever your normal inspiration is. You just take that off of how much you breathed in during that huge big breath. Okay? So that brings me to the inspiratory capacity. And so say that you breathe in 500 milliliters of air and you breathe out 500 milliliters of air. And then I was like, take that huge, big, deep breath in. That huge, big, deep breath in is your inspiratory capacity, the biggest amount of air that you can take in. All right. And so that's the tidal volume plus your inspiratory reserve volume. And that in this example is 3,600 because you can see 3,100 and 500 added together gives you that inspiratory capacity of 3,600. Now, the functional residual capacity, or also called the functional residual volume, is how much air is left in your lungs after you breathe out a normal breath. Okay, so your normal breathing, you still have all this air down here in your lungs, right? So we don't move all of the air in and out every single time we breathe. We keep some of the air inside of our lungs to help keep our lungs open, help keep our alveoli open. Okay, and so that our lungs don't collapse. The vital capacity just describes take the biggest, deepest breath in that you can and the biggest, deepest breath out that you can. All right, and so it's your expiratory reserve, tidal volume, and inspiratory reserve. It's the most that you can possibly breathe in and the most that you can possibly breathe out on your own, okay, actively. And then finally, the total lung capacity is all of these volumes added together. All right, so this is how much space there is total in your lungs for air. And what's interesting about total lung capacity is that it actually cannot be measured by the spirometer. Instead, you have to add these values together in order to calculate the total lung capacity. Okay. All right, so the last thing that I'm going to talk to you guys about is sort of a clinical case scenario, and we're talking about the role of carbon dioxide and pH. And so pH, hopefully you guys are familiar with what pH is. pH just measures how acidic or how basic something is. Okay, and so we are measuring how basic or acidic. Neutral pH is 7.0. Anything less than 7 is considered acidic. Anything greater than 7 is basic. All right. So with that in mind, the higher the amount of CO2 that you have in your blood, the lower the pH is going to be. Okay, and so lower pH, we're talking about making our blood acidic. So high CO2 makes our blood acidic. So therefore, if the lungs retain more CO2, the pH decreases, leading to an acidic state, and this is called respiratory acidosis. One of the biggest causes of this would be things like, let's see, high CO2 can be caused by COPD. It can be caused by pneumonia. It can be caused by anything that decreases your respiratory rate, like overdose or certain drugs that are CNS depressants. Okay, so anything that decreases respiratory rate, because remember, we're breathing in oxygen and we're blowing out CO2. If we are not blowing out CO2 at a normal rate, we are keeping that CO2 in our blood, and the buildup of CO2 leads to an acidic state. And that is what you're seeing. This guy down here is respiratory acidosis. And some of the side effects of that are listed here. Alternatively, we have the opposite situation where, say, you're hyperventilating. That means you are exhaling more CO2 at, well, I shouldn't say more, you're just exhaling it at a faster rate. And because of this, you now have decreased amounts of hydrogen ions, which is going to increase our pH. So if you are hyperventilating and you're decreasing CO2 in the body, then you're increasing pH, which means you're going towards becoming a basic pH of the blood. Okay. And one of the major causes of this, most common cause, hyperventilating due to anxiety or fear or pulmonary embolism. The other thing that can happen is if a person is being mechanically ventilated, so you're sitting there and you're squeezing the respiratory bag to help keep them alive, or the machine is doing it for them. If they set the rate too high, then the person can also experience what's called respiratory alkalosis. So alkaline means basic, okay, which means increased pH. Kind of one more fun fact about this, respiratory alkalosis, if you've ever hyperventilated or you've seen, I don't know, it's on TV all the time, they like give the person a paper bag. Well, this is actually really helpful because essentially this person is blowing out CO2. So by breathing into that paper bag, now they are re-inhaling that CO2 that they just blew out to prevent respiratory alkalosis from occurring. So it actually is a helpful way to manage prevention of respiratory alkalosis. And that is all that I have for you guys. And so if you have any questions, let me know. But other than that, I am all done. Have a good week.